Okay, I'm going to go ahead and introduce Leslie, our next speaker. And then after Leslie, we'll have a short break and then our last keynote speakers. Okay, so it is my great pleasure to introduce Leslie Carpenter as our next speaker. She's a dedicated mental health advocate who spent years raising awareness, educating communities, and working directly with policymakers to improve access to care. She co-founded Iowa Mental Health Advocacy, a grassroots organization that gives voices to families and individuals impacted by serious mental illness. She serves on the NAMI Iowa Board of Directors. She has successfully led efforts in Johnson County to create Iowa's first assisted outpatient treatment program in conjunction with Iowa's first civil mental health court. She also serves on multiple advisory boards and committees as a family member with lived experience, including the National AOT Advisory Committee. Please join me in welcoming Leslie Carpenter.
Hello, everyone. I'm going to ask you to indulge me for just a moment. I'd like to have a show of hands of how many of you out there in the audience know what anosognosia is. All right, wonderful, thank you. I'm hoping by the time that I get talking and my lovely friend Eric later on gets done talking, that you'll have an even better understanding about what it is and how it can create some real barriers to treatment and to communication. And that's why I've labeled this talk about bridging the communication gap caused by anosognosia. And when I say that, I have two meanings there. One is the ability to communicate with someone who has anosognosia, and then also how we can do a better job communicating collaboratively around someone who has anosognosia to help them be able to get to treatment. You already heard my bio, so I'm not going to really hesitate on this slide for too long, other than to let you know that I am not a mental health professional. I was a physical therapist in my first career. But I left that career about 6 years ago when I recognized that if I wanted to accomplish a lot of the changes that I wanted to happen for improving the care of people with severe mental illnesses, I needed a lot more time in order to do that. And so I've become very active at the local, state, and national level. And I do work for the Treatment Advocacy Center now on a part-time basis. And while they offered me full-time, I took it part-time so I wouldn't have to feel guilty about all the other things I'm trying to accomplish here in Iowa. I wanted to have time that I didn't have to feel bad about. So why? Well, we have 2 adult children, and I'm very happy to tell you that our daughter is really healthy and well. She's thriving. Our son is not. He lives with a very severe schizoaffective disorder complicated by a co-occurring substance use disorder. But just like most of the people who develop one of these illnesses, he started out as a very healthy, happy, normal kid. He was funny and artistic and athletic, caring, and very, very bright. And you can see his little sister just adored him. But this picture here on the far right is the last one we have of him before he got sick. And that happened to be his girlfriend at the time as they were getting ready to go to a homecoming dance at the high school. And then things changed. And just like most families, we thought we were dealing with teenage rebellion. But pretty soon it became clear that that wasn't it, and he was very, very sick. And this is a self-portrait we saw at the time, where you can see the sadness in his expression, but also the beginnings of some concerning imagery starting to show up in the background of his artwork, his homework, his notes. But this self-portrait is unfortunately probably much more reflective of his experience during the early years, and probably still now. And it's a picture that we did not see at the time, because just like most young people hide their symptoms for as long as they possibly can from their loved ones, he hid this amongst his many, many sketch pads. And so for the past 17 years, this has been our life. For our family, I would tell you it's been a nightmare. For him, it's been a living hell. He has gone through the revolving door churn of all of these hospitalizations and placements, trying to live in our home, trying to live in an apartment with our support and community services. And it wasn't until he'd been sick for 14 years that he finally got an extended stay at the state hospital in Independence. And I'm going to stop here and just hesitate to point out that there's been a lot of propaganda about state hospital care. We were told that the state hospitals here in Iowa were terrible. I'm here to testify for you that they are not. They are the best level of care that our son has ever had. I wish he'd had access to it far sooner because I think he would be far less sick if he'd had that. It provided structured, secure, multidisciplinary, compassionate treatment that addressed him as a whole person. He got caught up with medical needs, dental needs, vision needs. He met with a psychologist on a regular basis for the first time that he ever did over the course of his illness. I'm here to tell you we should not be calling state hospitals the place of last resort. They are a needed component of our continuum of care. And we need to change our mindset about that. Because currently, that's the only place people can get extended care. And we all know, if we're really being honest about it, no one finds the right medications when they're having that first psychosis in a 2-week stay or a 72-hour stay, right? So I share the picture of the brains below because what I hope for you to hear from me today, if nothing else, is that because mostly we are unable to have somebody go to the hospital when they're having their first psychosis and stay there, or some other level of care with enough support and stay there long enough for them to figure out the right cocktail of medications and therapies and supports that the person needs. Because we can't do that currently, we are actively, as a society, causing people to become so much more sick than they have to be. And I'm determined to change that, hopefully, before I die. So I'm going to give you a little bit of a definition. You've been hearing today a lot about serious mental illness. At the Treatment Advocacy Center, we focus in on people with severe mental illnesses. So what's the difference? We're focused in on the people who are not able to get to the care that they need. They have psychosis-related disorders, right? And they are most at risk for the adverse consequences of homelessness, incarceration, and death. And it's an important statistic to point out that in 2022, among the 15.4 million adults in our country who have an SMI, only 66% of them are treated in a year, okay? So what's that mean? It means amongst us living in our country, we have about 5.2 million people who are untreated or very significantly undertreated for their severe mental illnesses. Okay? In Iowa, it's about 49,000. It is no wonder they are intersecting with our criminal legal system. So psychosis. I wanted to kind of give some examples of this. There's a lot more clinicians here than I thought there were going to be. I thought I was going to be talking to more people from the judicial branch, so bear with me. But psychosis is basically a brain condition in which the person is having an illness, right? It's under attack. It's not all that different than a stroke when we think about this from a medical standpoint. It causes them to have an altered perception of things happening around them. It causes really diminished cognitive processing, again, of the information around them. It causes changes in their emotional affect, behavioral impacts. An example from our son is one night he showed up in the middle of the night, honking the horn as he drove up the hill to our house, came crashing in through the front door and said, "Mom, Dad, there's a gang of killers coming to kill us. I need you to call 911 right now." Pacing, amped up, terrified, right? That, my friends, is psychosis. Common features? Hallucinations. They're seeing and hearing things that we don't. Most commonly, it's hearing things, right? A lot of terrible voices. Delusions. "Mom, I just died. But don't you worry, because I've come back to life and I'm God, and I need you to come get me and take me to go see Obama, because I've got to save the world right now," right? That was his first psychosis. Completely gone. Negative symptoms. They're retreating within themselves, right? Retreating even to the point that they're covering up, masking so many clothes, right? I'm sure you've seen it. Retreating into bedrooms, retreating into basements. Disorganized thinking, disorganized abnormal motor behavior, and paranoia. I wanted to mention paranoia because we sometimes forget that the person is having paranoia, right? My mom and dad are imposters. They're not really my mom and dad. They're working with the devil. They're trying to kill me, right? I know that most of the medical providers that have seen my son have heard horrific things about us that are based upon paranoid delusions. They have paranoia mostly about the people that are closest to them or the people who are taking care of them at the moment, right? And so when you're hearing that, please don't assume the families are terrible people, because most of the time they're not. And here's another key point that I really wanted to make sure you all understand, is that there are severe adverse consequences and effects of leaving people in untreated psychosis. It is doing sustained damage to the brain. And in our country, the average length of time that somebody is untreated for a psychosis is 74 weeks. That's well over a year. Would we accept this for any other medical condition that is life-threatening? It causes reduced responsiveness to treatment. It makes the illness more treatment-resistant. It makes it harder to bring them back out of that psychosis, right? And the more times they have a psychosis, that adds up. And I want you to hear me say the way that I said that. The illness itself is more treatment-resistant, not the person who's unfortunate enough to have ended up with that illness, okay? It causes more severe symptoms, it causes less insight over the course of time, and it does cause neurotoxicity, right? I think of it as an acid eating away at the brain. And all you have to do is look at this picture of this brain of the person who has schizophrenia. There's holes in that brain, right? That's the result of being untreated. So the question is why? Why is that happening? Well, it's a number of factors, right? It's complex. But one of the factors is that instead of medical judgment, deciding when somebody is able to access the care that they need for being in psychosis, it's a law. And I pulled some of this language directly from Chapter 229. And the part of the law that is most applied by the actual people that decide about making an admission is whether a person is dangerous to self or others, right? If you cannot answer the doctor, yes, my son is suicidal or homicidal, I'm not going to get him in the hospital, right? And there's other criteria, though, that are often ignored. When I read this one, is likely to inflict serious emotional injury on members of the person's family. I was really stunned, because do you think over the past 17 years, anybody ever asked me if I was experiencing an emotional injury from my son being in untreated psychosis in our home? The answer is no. No, not one person's ever asked that. But it was there, okay? Is unable to satisfy the person's needs of nourishment, clothing, essential medical care, or shelter. We don't pay attention to that one either. And how do I know that? We allow people to freeze to death on the street rather than treat them, okay? Has a history of compliance with treatment, of lack of compliance with treatment, and any of the following applies. It has been the reason that the person's qualified for emergency hospitalization again, and it's been something that has resulted in one or more acts of violence towards self or others. That's the part of the law we added in 2018 to allow for assisted outpatient treatment that Lynn has been so wonderful in getting started in Johnson County. So then the next question is, why are the criteria being ignored? Well, lots of reasons that we know from being on the ground, right? We don't have enough beds. We are 51st in the country for our number of psychiatric beds. We are severely underbedded with only 2 per 100,000 for our state beds. And the recommended ratio for both state and public beds, state and private beds, is 50 per 100,000 people. We are severely underbedded in our state. The other thing that's come up is somebody is too sick, too suicidal for admission. Unbelievable. Do you know what the answer is then? Go home. Don't die. Good luck. I can't believe that happens, right? Okay, lack of insurance coverage for inpatient stay. We have ceded decisions regarding medical treatment to insurance companies rather than medical doctors who should be making that call. We need to reclaim that power. If a substance has been used, and that's been found to be the cause for psychosis, what's happening to people here in Iowa and all across the country? Do they get held? Do they get sent for treatment? Most often not. They're getting streeted. They're getting sent right back out. And I want to talk about this because what's the consequence of that? The person's going out, they're having better access to the street drugs that are making them more sick, raising the aggression, increasing the workplace violence, and the hospitals are doing it over and over and over again. They say the definition of insanity is doing the same thing over and over again and expecting a different result. The answer for that is put your foot in that revolving door, hold the person, get them into treatment, and then they aren't going to go out and get more sick and more violent. Okay? And then the last one is the cultural mindset that has taken place because of all these complexities. Okay? If they don't want treatment, that's their choice. And let's just take care of the people who want treatment. The number of times I've been told that, I can't even count. What I'm here to talk with you about today is that for the majority of these people who are not in treatment, the 5.2 million people, it's not that they are making an active choice with capacity, with a healthy brain. They don't know they're sick. They cannot stay adherent to treatment on a consistent basis. So let's talk about all the reasons for non-adherence. There's a lot of them, right? They may not have insurance, they may not have transportation. It may be the horrible side effect profile of these psychotropic medications. That's a real factor. It takes a long time of close collaboration between a doctor and a patient to get that figured out. Mistrust, right? Paranoia is a key symptom. They're afraid of what the doctors are saying. They aren't going to pay attention to what mom's saying, let me tell you. But the biggest barrier to treatment in our country is anosognosia. So what is this? And I want to make sure I'm defining it for you, because what I heard initially when a doctor first told us that our son lacked insight, what I heard as his parent was, your son is dumb and in denial. That's what I thought, because they didn't use the word anosognosia, so I couldn't go look it up, right? So it's important to understand what this is. It is a manifestation of the brain illness itself. It causes changes in the frontal and parietal lobes that makes the person know that they are not sick. Not believe, know. So it's very different than an adult being newly diagnosed with diabetes who doesn't want to have to bother with diet and exercise and medication, right? In that case, their pancreas is a sick organ, and they're making those choices with a healthy, intact brain. This is very different, and it's common with other neurological illnesses. And I want to point out that you're about to hear a video that I'm going to play for you where the doctor is going to cite some older data about 50% of people with schizophrenia having anosognosia and 40% of people with bipolar disorders. But the more recent data found in review article by Dr. Henry Nasrallah, who is a psychiatrist in Ohio in 2022, found that it's actually present in about 57 to 98% of people with SMI. So it's much more prevalent than what we previously thought.
Anosognosia. Anosognosia is exactly what I think you have. I believe that my son, Chris, over the course of repeated breakdowns, lost his capacity to understand the things. It's so hard when you understand and actually never to think of it. You absolutely justify this rather than
order, sir. Russell Weston is one tragic example. Mr. Weston came to Washington, D.C. to, quote, save the world from cannibals, and killed 2 Capitol police officers while in this delusional state.
When the cannibals, I have control of the British satellite system, and they are being criminally prosecuted for murder and cannibalism, then they say, well, the Rudy Timer system means that they are not permanently dead, so they cannot be criminally prosecuted for murder.
You've been prosecuted and having control of time and sleep.
Well, that's
Can
fine.
you make them come alive by your choice?
Yes, I can do that, yes.
But you wouldn't?
I usually do not know.
Weston was not taking medication because he did not believe he was sick.
If theoretically, AJ and Barry did recommend insanity defense, would you go along with it?
No.
Why not?
That is not advantage in my position.
First of all, do you perceive yourself as being mentally ill?
No.
All right. Is that the primary reason that you rejected insanity defense?
That's correct, yes.
Bear County Judge Holly Jackson Spencer developed the first of its kind outpatient commitment program in Texas. She saw the devastation caused when the severely mentally ill are too sick to seek treatment and end up trapped in a revolving door of incarceration, homelessness, hospitalization, and victimization.
So you can't simply tell someone who has a mental illness and is disorganized in their thinking, hey, you've got a doctor's appointment in 3 weeks and it's, 10 miles from here, these are the different buses you need to take to get there, and don't forget to go, and assume that they're going to make that. That's just not going to happen.
Judge Oscar Kazin supervises the day-to-day operations of Bear County's court-ordered outpatient treatment program. He meets regularly with patients, psychiatrists, and staff.
When I sit in that little courtroom down in the basement of that abandoned hospital, the San Antonio State Hospital, the guy who sits at the end of the chair, that mentally ill patient, didn't have a choice. He didn't wake up one morning and say, I want to lose my life. I want to lose my sanity. These people had no choice in that. And it's our responsibility to bring them back to sanity. They didn't choose it.
It's very important to understand that anosognosia is the #1 reason why people fail to seek treatment. It's up to the rest of us to make sure that they are able to get treatment.
So I want to point out for a moment that Russell Weston, the gentleman that they were referring to there, he was both really smart, right? He had an outstanding vocabulary. He was simultaneously extremely bright and unaware of his illness. And I think that's a combination. If you think about your patients that you see, it's pretty common, right? And it's part of the challenge of it, because it's a really difficult thing to work with somebody who is completely unaware of something, but very bright about lots of things in terms of how they talk with doctors. They can look really good for about 10, 15 minutes, right? No, I'm not suicidal. I'm ready to go home. I'll take my medicines, but have no intention of doing that or ability. So, what can be done about anosognosia? The #1 answer seems obvious, but I'm going to say it: treatment. We need to get these people treatment no matter how we have to do it, okay? Medication, cognitive behavioral therapy for psychosis is known to be evidence-based and effective. The LEAP method. If you've never heard of Dr. Javier Amador, he's written the very famous book, I'm Not Sick, I Don't Need Help. He teaches LEAP training, which stands for Listen, Empathize, Agree, and Partner. If you haven't ever heard of that, I highly recommend taking a look at the website that he has for the LEAP Institute. You can also find videos on our TAC YouTube channel and website. It's highly effective. There's a lot to it to understand how to do actual effective, reflective listening and engaging with people. Motivational interviewing, you've already heard that talked about, so I won't belabor it, but I will tell you that a lot of the people that I have met who have graduated from AOT programs or had effective interaction with providers and have come to more full recovery, what's been the key difference between what they got and what my son got? They had someone ask them, what are your goals? They had somebody believe in them. Oh, you can reach those goals, and we're going to give you support about that, right? You're going to take your medication, and it's important to do that so that you don't have further brain damage, and you can still reach these goals. They're giving the person hope. That's not happening enough for these patients, okay? Engagement strategies. One of the examples from the AOT program in Johnson County was they had a patient that was due for their next long-acting injectable, but didn't want to go. So they asked the person, why? Why not? Well, the person didn't want to have to get their long-acting injectable on an empty stomach because it always made them feel sick for a day or two afterwards. Oh, well, that's easy to solve. Let's pick them up, take them out for lunch, and then go get that medicine. Another month of meds are on board, right? You do what you have to do to get the brain treated. Okay, assisted outpatient treatment. I'm going to share some more outcome data about that because you need to hear it. And communication with care partners is what we're going to also talk about in a moment. But I wanted to share some of the outcome data from the first year and a half or so. This is for the first 23 patients that were served between May of 23 and November of 24. Those ED visits were reduced by 77%, hospital admits decreased by 73%, hospital days reduced by 90%, and crisis stabilization days reduced by 53%. When you tally that up, that was a cost savings of $2.1 million. For that initial investment of around $170,000 a year. I think it proves the point that it's cost effective, and that's not even looking at the other part of the system where we also save money, not going back into jails, right? Okay, how long does it take to get help? Dan Garza runs the program of AOT in Queens County in New York, and what he found is that if they can keep people in treatment for about 12 to 18 months, about 90% of them get enough of the key connection between staying on their meds and staying out of the hospital that they get it, and then they go on to more independently manage their lives after that. And that makes sense if we think about brain chemistry and the amount of time it takes for someone to actually have their brain heal up and regain that cognition and connection, at least of that point, right? Because anosognosia isn't just black and white, it's a sliding scale. It comes and it goes, right? Especially early. Similar findings have been found with the last independent study that SAMHSA paid for of the last batch of AOT grantees. And what they did is they took a look at how about people that were kept in the program for 6 months versus shorter. The 6 month people did far better than the people that were in it for a shorter period of time. Okay, communication with care partners. So the American Psychiatric Association recommends attempting to contact and involve a family member should be part of standard care for mental health inpatients. How many of you in the audience think that's happening on a regular basis? Anybody? Okay. They did a study in New York of inpatients, and they found that 92% of inpatient psychiatric patients did want the family involved in care planning. But most of the people that had gone to training at certain periods of time in the past were taught, no, you don't want to ask for an ROI for the family, right? I know that that's the case. I've talked to providers about this. So let's talk about what HIPAA is supposed to do. It was intended to protect sensitive health information and records, but also requires providers to keep medical information confidential unless sharing with other providers to ensure continuity of care or with caregivers to ensure patient well-being and safety. So my question for you all is, can we think of a diagnosis that is more at risk in terms of being able to maintain safety and well-being than someone with schizophrenia, especially someone with schizophrenia who doesn't know it, right? This patient population is at high risk, but we don't want to talk to the families. So what if there is no release of information? Can you still talk to the family? Yes, if the patient is not present or incapacitated. Mom, I need to go save the world. Do we think he had capacity at that point in time? My answer is no, he didn't. He was demanding to head to go see Obama, right? And so it's important to understand that you should be thinking about this. If I were bringing in my mom who had Alzheimer's, a medical provider would be considered negligent if they didn't communicate with me as her primary caregiver to ensure that she was getting her medications and treatments and supports, right? We should be thinking that way for people with schizophrenia and other forms of severe mental illnesses. It's negligent not to. So why does HIPAA keep getting in the way? Misunderstandings have led to strict non-disclosure policies, right? I talk to families all the time. I took our child to go get into the hospital. I know he got admitted. I call the psychiatric unit to call and ask to speak to the nurse or the social worker or the doctor, and what do I get told by the clerk on the other end of the phone? We cannot confirm or deny that he is a patient here, right? It's cruel and it's harmful to the person, okay? HIPAA never blocked families from being able to share information to providers. But we do meet that hand, right? We meet that brick wall. So I can't tell you the number of times that I've provided the printout of what HIPAA is and the Iowa code, because in Iowa in 2016, the HIPAA code was modified, right? It allows, if a family has been documented to be supportive and helpful in keeping somebody in treatment, there is two-way communication that is supposed to happen, right? So we provide that documentation to families, and they ask and tell them to take it in and inquire and make sure that they get communication. Because how are we supposed to take care of somebody if we don't know the diagnosis, we don't know the medications, we don't know when their follow-up appointments are? And then you wonder why they look like they're abandoned, okay? And information sharing is allowed to prevent or lessen a serious health or safety concern. I wanted to reiterate that point. And why is it important to communicate with families? Because when somebody's in psychosis and think that they need to go save the world, they're not a good historian. They can't tell you what their diagnosis is. They can't tell you anything with accuracy in terms of their medications. It's really helpful to just make sure you have a basis of information. And we train families to have a one-page document with a diagnosis, current meds, other things that are critical to know, right? And we can also be your eyes and ears for all the time that you're not with the person, and we are. Let you know how those medication changes are going. Are they sleeping? Are they taking their meds? It really helps to enhance the understanding of what's going on. And for those of you in the criminal legal part of things too, it also helps to talk with us so you have a better sense of what the context is to make decisions. And we also want you to know that not all mental illnesses are caused by trauma, right? Especially severe mental illnesses. These are genetic, biological illnesses of the brain. There often is an environmental trigger, something sets it off, right? But having said that, I also want you to know that I fully recognize that the mental illness itself causes trauma for the person who has it, right? Think back to that drawing my son drew of his head exploding. Nobody can tell me that he hasn't been traumatized by his illness. He's also been traumatized when we took him to get medical treatment, right? He's been chemically restrained, physically restrained. He's been blamed for his illness. He's been blamed for not responding to the medications that were tried. It's pretty traumatic to be a patient with a mental illness. And I also want you to know that in most cases, especially for SMI, the family dysfunction wasn't present before the onset of the mental illness. The mental illness brought dysfunction to the family. Imagine you're bringing somebody home from the hospital who's not even stable yet, still thinking they're God and that they need to save the world, and that those medications that the mom who's 5'6" is trying to talk her son who's 6'3" into taking that he thinks is poison. Does that bring conflict into a family? Yes, my friends, it does. It's horrible conflict. And I love this other quote. It's an anonymous one, but it fits. Mental illness didn't run in our family. It strolled in, and it took its time with all of us. This was really hard on our daughter, who was 4 years younger. She was 11 when he got sick. We worked really hard to keep things normal for her, but we didn't, right? Keep that in mind when you're first meeting families. We've been through a lot. And we want to remind you that all we want is the same thing that any family would want for somebody with a chronic, disabling, right, life-threatening illness. We want compassionate, effective, person-centered treatment so that they can do better and thrive and not suffer as much. And we should not be vilified when we are advocating, even fiercely, for wanting that treatment for our loved ones. But it happens all the time. And I know a lot of you feel that the families are walking away and abandoning the people that you're intersecting with that have severe mental illness. And that does happen, okay? Not as often as you think. Part of the reason that happens is that families are greeted with the hand. Go away. Don't bother us. We don't want to talk to you. So do we know enough about the illness? Do we know enough about the medications? Do we know enough about how to communicate with our loved ones? In a lot of cases, we don't, especially at the beginning. We have no idea. This is all new to us. At least hand us a brochure with a diagnosis, right? Refer the people out. Send them to NAMI. I promise you, family to family was a life changer for me. No, family to family was a lifesaver for me. You can also refer them to the Treatment Advocacy Center. We have a wonderful resource center with amazing amounts of resources for families and people living with mental illnesses. We have a helpline, okay? Highly recommend at least refer them to somewhere to get some help. So what happens when SMI isn't treated? Those 5.2 million people. The care is falling to the systems that can't say no. And currently, who is that? Law enforcement, courts, and corrections. It used to be emergency departments couldn't refuse somebody. And really, per the federal law, right, EMTALA, they're still not supposed to be able to refuse anybody, but it's happening on the ground, right? We all know that, if we're honest. And I know that all the people that are in law enforcement, courts, and corrections did not go to college and pursue these careers thinking, I want to go out and help people with mental illnesses, right? And so we're so grateful to those of you that do, and so to all of you that do crisis intervention team training, all the people that learn about de-escalation. We are so grateful. But the result is that most of these people are ending up in what we call the SMI churn. And this is a term that was coined by a reporter based out of Washington State. She was the reporter that participated in the Lost Patients podcast. And if you haven't heard that, it's on NPR. It's amazing. I'm a lifelong learner, and I learned quite a few things from listening to that were very helpful. But what we're talking about, we used to call the revolving door. And I realized that the term churn is much more accurate, because what happens is people are going through those revolving doors and getting worse and worse and worse, right? That's not fair to them, and we can make a difference. And what I'm hoping from this conference and talking with all of you, and I'm so encouraged by all the times that I've heard the words communication, collaboration, cooperation, with that, we can put our foot in those doors, right? I do also want to address the constant question that comes up about, does severe mental illness cause violence? And I want to make the point that if people are treated, they are not any more violent than any of the rest of us. They're not. But when people are left untreated and undertreated, we have to admit and know that it does tend to lead to more aggressive incidents. Most of that violence is directed towards self, right? It's 2/3 of it are suicides. Same statistic holds true for gun violence. 2/3 of all gun deaths are suicides, right? And violence is most often directed towards caregivers and family, okay? So the real thing on the ground is, and it gets worse if there's substance use disorder on top of that, right? The number one person killed by somebody with a severe mental illness is mom. Then it goes to dad, and then it goes out, right? It's important to understand when you're meeting a family that says, no, I'm sorry, my son can't come back and live with us ever again. That is fed by fear, but a fear that's based in reality with the headlines that we all read every day. We are creating a boundary, a healthy boundary, but also a boundary of safety. And we are still there engaged and advocating for our loved ones, even if we can no longer allow them to live with us. We were told over and over and over again in the early stages, your son's really sick, he needs a higher level of care, and we'd say, yes, we completely agree, we can't keep him on his meds. Where can we send him? And do you know where they sent him? To our house, over and over again. We were not able to meet the needs of our son by ourselves. We didn't have the knowledge and expertise and resources to do 24/7 support for our son. We still can't do that. But we shouldn't be vilified about that. So, how can you help? Ask for the history. Reach out to the families. We can give you information that will help you. Find ways to divert. There was another word for that too. Move them to treatment rather than move them into the jail. Please, please, please. Take advantage of the crisis and access centers. Take advantage of the jail diversion programs. AOT programs are highly effective, and my goal wasn't just to get the first program started in the state. My goal is to get it statewide. I set big goals, and it took me 5 years to get to the first one, but I'm still going to be dedicated to getting it more. If you are sitting out there and you're thinking, we would like to have an assisted outpatient treatment program in our county, please take down my email, which is on the last slide. Email me. I will come and support you. I'll help get stakeholder engagement. I will help you get buy-in. I'll help connect you to our AOT implementation department at the Treatment Advocacy Center. I'm here to help you, and I'm sincere when I say that. Mental health courts, we want definitely more criminal mental health courts as well. I'm pushing for that in Johnson County, no surprise there. We want responsible discharge and release plans. I'm so pleased to hear about this new jail-based treatment and that it's going to the bridging to connect to treatment, which is really great. But there's also the idea that you can also have responsible hospital discharges. We have a bill that made it through the House during the last session in the legislature. We need to get it through the Senate. Why is this important? If we set the person up with the appropriate connections to treatment after they come out of the hospital, if we actually do a suicide assessment before we discharge them, knowing that they're most at risk for suicide immediately following a hospital discharge, if we know they have case coordination and case management, they are less likely to end up in the churn. If you agree with me and think we need to be mandating responsible hospital discharges, please write to your state senators. Help us get that over the finish line. And help us to advocate for positive changes everywhere. While those of us in the room and other places are working on doing system level kind of changes, legislative changes, coordination changes, in the meantime, what I want you to all know is already within the broken and very siloed system that we have, you can accomplish a whole lot of good with more communication, more collaboration, and more cooperation. I've seen it. I've seen people who I know I have on my phone that I can text and say, I got a person in trouble, can you help me get this person into treatment? Then can you help me make the hospital hold the person long enough so that we can get the person into the level of care that they need, right? If we take that amount of effort and step a little bit outside of our bounds that we think we're stuck in, you can save lives. I've seen it. And what I'm basically asking you to do is to take the starfish approach. Take care of each person, one person at a time. Get creative. Figure out how to make the connections. Please don't ever again in your lives say, I am so sorry, there's nothing I can do, I don't have the authority to do this. I'm standing here as a person who has no authority in this state to do anything, and yet I think I get some stuff done. I know all of you can also do that because you have a whole lot more authority than I ever will dream of. And with that, I'm going to say thank you so much for listening and open it up to any questions you might have.
As a clinician, I'm struck by the disconnect between our ability to appreciate anosognosia in things like dementia, but not in something like schizophrenia. And I didn't know if you had any thoughts that would help move that needle beyond. Maybe it's something like, well, nope, we need training, education, I'm not sure, but that just seems like something of a slap you in the face, obvious space that I think you're right, we still see, we don't appreciate it at some level.
Yeah, I completely agree. We do recognize it for that. We recognize it for stroke patients too. I've had patients with complete paralysis of their left leg, and they'd stand up and fall down. There's no telling them that they have paralysis, right? This is an opportunity for education, and my role at Treatment Advocacy Center is changing this month. I'm going to be doing a special project really geared around more education of very specific SMI-related education for medical providers and direct care staff, and that's a big thing that we want to be educating people about. Anosognosia, psychosis, all those complexities that are unique to people in psychosis and psychosis-related disorders. Yeah, and it comes down to storytelling and much more education around it. And I think part of the other thing that I would say is that people, there's so much, I hate the word stigma because it's not my thing that I really work on, but there is a stigma. People think that people are making a choice. And it's important to know that they're not. It is brain dysfunction that's causing them to not be able to stay engaged on a consistent basis. And it's even worse for people with substance use disorders. But I also want to make the point that substance use disorders are also brain-based illnesses. These are not choices that these people are making once they're addicted, right? There's changes in the brain, and I think personally that when somebody has both a mental illness and a substance use disorder, that level of anosognosia goes higher. I have no data to back that up. That's just my experience. Yeah. Yeah, I think that's really good. It is going to be showing up. I believe there's movement on that in terms of the DSM. The other thing I can tell you is in the state of Texas, Eric probably will mention this more than I can, but in the state of Texas, they actually changed their commitment laws so that anosognosia is recognized as part of the criteria for deciding if somebody needs involuntary inpatient treatment, which is really important. And outpatient?
So anosognosia was added for police to be able to bring someone to treatment without a mental health warrant now, which is great. Well, we're going to talk all about this.
Yeah, Eric will address that later for you.
I don't have a question. I guess I just have a quick comment. I don't know if you know me, but I know you, and I just want to...
I know you. I came and visited your court twice.
Okay,
maybe 3 times.
Okay. I just want to thank you for the work that you do throughout the entire state of Iowa. I think your personal experience is extremely impactful, and I know it's not always easy to share, but I feel like what you're doing makes a difference. Thank you so much. I wish I could put you in my pocket and take you places and have you talk to so many people because they need to hear what you have to say. And I feel like I just sat here and I was like, So I know I'm not the only one, but truly thank you so much for what you do. It doesn't go unnoticed.
Thank you. And please say hi to Patrick for me. May I say one more thing? You guys are so lucky in that you're going to get to hear from my friend Eric Smith, who I've known for a lot of years, and Joe Smarrow. You guys, I can't tell you what a treat you're in for with the next speakers. So thank you.
Thank you, Leslie. You may not have the authority that you think you have, but you have a very strong voice, and so you're an advocate for everybody, and so you do amazing work. So we will go ahead and take a 15-minute break and then come back for our final keynotes.